Thank you for joining us for part two of our Straight Talk series on scoliosis. My name is Tim Borden, and I'm a pediatric orthopedic and scoliosis surgeon, and I'm part of the excellent team of scoliosis and spine surgeons here at UT Health. I'm joined today by two other team members and my colleagues.
Hi, good evening. I'm Dr. Lindsay Crawford. I am also a part of the Pediatric Orthopedic and Scoliosis team.
Hi, I'm Dr. Surya Mundluru, and I'm also one of the members of the Pediatric Orthopedic and Scoliosis team here at UT Health.
I hope you all tuned into our part one of the series with our other team members, Dr. Dodwad and Dr. Yunus. I just wanted to go over a couple things that were discussed in more detail at the last part of this series. First of all, what is scoliosis? To refresh, scoliosis is a curvature of the spine that's seen in the frontal or coronal plane, and it either comes in a C or S-shaped curvature, and it's usually diagnosed definitively by X-ray. A couple other things to keep in mind is there are different types of scoliosis, and while the most common is adolescent idiopathic, there are a lot of other different types, like congenital, which is present at birth. There's neuromuscular scoliosis, which results from an underlying medical condition. And then there's idiopathic. By far the most common, about 80% of the scoliosis we see is idiopathic, and its cause is undeterminate, and we're still trying to figure that out in 2020. I just want to dive into treatment options, but first to get started, Dr. Crawford, why do we treat scoliosis?
Right, good question. So you may know somebody who has scoliosis, or you may have it yourself. And so you realize that many of our patients with adolescent idiopathic scoliosis go on to live normal lives. They're able to work any job they want to work, not limited in their activities. But those patients that have larger curves at the end of adolescence going into adulthood can continue to have issues. Those large curves can continue to progress when they're adults and get larger, causing more deformity. They're also at risk for increased back pain, potential for needing a back surgery, and as well as if the curve gets very large, they can actually have pulmonary issues. So it's because of that our goal of treatment is to prevent the patients from getting to that point of having a very large curve that'll affect them into adulthood. And so for us, when we're approaching our treatment, we have to think about how much growth does the patient have remaining, because the curve can continue to progress while the patient is growing, and what's the size of the curve. We measure what's called the Cobb angle, which is basically the degree of how curved the spine is, to make a determination of what's going to be the right treatment for that patient. So young kids with larger curves are at risk for progression, and those are the ones that are going to have a more aggressive approach to treatment. So what factors exactly help us decide how to treat our patients, Dr. Mundluru?
Great points you made, Dr. Crawford, and a great question you asked. So to echo what you said, the age of the patient is very important in determining how we'll treat the patient. If a patient is young with the initial onset of scoliotic curve, then there's a higher chance of progression as the patient grows. So we're going to be more aggressive about doing options such as bracing. If they're older, sometimes we can get away with observation and not have to do anything more than that. So the age is a very important determining factor in terms of treatment. There's a terminology that we typically throw around in scoliosis management called a bone age. What the bone age is the actual age of the patient's bones. For instance, you can have a 12-year-old that has a bone age of 14. Though their chronological age is 12, they may be more mature from a bone standpoint. So we may be able to get away with observation. But if it's a 13-year-old with a bone age of 11, we may have to be a little bit more vigilant, and we may have to do things such as bracing or other treatment modalities because they have a lot more time for the curve to progress. The size of the curves are also very important. The curves can happen in various parts of the spine and locations of the spine. And the size of the curve when the patient initially presents to our office is important because that can determine the length of treatment, how aggressive we have to be with treatment, and also give us a prognosis as to how effective our treatment will be. Location of the curve, very important. Lower curves in the lumbar region tend to have a lower threshold within which we have to consider surgical options compared to the curves in the thoracic spine. The status of the menses in females is important because once a girl has the onset of her menstrual cycle, that means that they're probably going to have a decreased risk of progression in the future. Once again, there's a lot of variables that play into effect, but that's an important thing. And in boys, we look at their puberty, how mature they are. In terms of gender, boys and girls tend to have scoliosis at equal rates, but girls tend to have an increased risk of progression or have worsening scoliosis. So gender is an important factor that we look into in terms of management and treatment. And once again, as the curve progresses, we have to think about other options to try to get control. And in the most severe cases, that sometimes entails surgery. So a question that I have is, what do you do for small curves, Dr. Borden?
Yeah, so the vast majority of patients who get referred to our office and who have detected scoliosis on their school screening or from their pediatrician fall into this category. They're smaller curves. And when we get the x-ray and we measure that, the curves are below 20 or 25 degrees. Those we can easily keep an eye on and make sure that they don't continue to progress or become larger with time. Also, if curves are less than 40 or 45 degrees when children are done growing, we can simply keep an eye on them to make sure that they don't become worse. That observation is not just letting you go and not following up at all. We like to carefully follow up children with smaller curves because a certain subset of them will get larger. So we'll have them have the patient come back to the office for a clinical evaluation and x-rays anywhere between 4 and 12 months, every 4 or 12 months, depending on how quickly the child is growing. And occasionally, with people with small curves who have associated back pain, we may recommend some physical therapy to work on core strengthening and back exercises to help out with that pain. Now, when curves get into this middle category, when they're somewhere above 20 or 25 degrees in patients that are still growing, that's when the conversation about intervention really starts. And that intervention most often is bracing. So bracing is very, very successful at correcting the spine. And you can see in this x-ray here, a child who has a pretty significant curve in her spine is getting good correction with that brace to help guide the spine into a straighter position during time of growth. Now, it's important to know that bracing does not correct the curve. It doesn't straighten out the curve that's already there. The main goal is to prevent curves from getting bigger during times of growth. So that's the whole purpose of it. And it can be really, really successful, but it does have to be worn. Which brings me to my next question that I think a lot of people have, and I'll address this to you, Dr. Crawford. How many hours a day should kids be wearing their brace, and why does it even matter?
Right. So you mentioned how bracing can be very successful. And a brace like this is a very traditional style of scoliosis brace that we still use today. This is called a Boston brace. And so, you parents may know somebody when you were a kid, a friend of yours, or maybe yourself, that had to wear a brace, and they're probably wearing it for 23 hours a day. And so we looked at, do we really need to be in the brace that often? We understand that our patients are active, they have sports, they have dance, they would love to have time not in brace as well. And so fortunately, there was a large study done in 2013, and we looked at how many hours in the brace is going to be very effective for preventing the progression of scoliosis. And we found that that number is actually 18. And so based on that study, you will find that many physicians use this as a recommendation of time in the brace. So 18 hours a day, usually a good chunk of that's going to be at nighttime while you sleep, and then figure out what's going to work with your schedule during the day. So bracing is very effective at preventing progression with numbers of over 90% at holding a scoliosis where it is. But compliance is key to that. There are even braces that have compliance wear monitoring that are available now so that we can keep track of how our patients are wearing their braces. So again, it's a great method, and it is a temporary thing is what I always remind patients. It's not a brace you're going to have to wear forever. It's something that we're going to utilize while they continue to grow to control that scoliosis. And when they're done growing, then they can discontinue the bracing. So it's a temporary thing to keep the scoliosis from progressing on and requiring a surgery potentially. So Dr. Mundluru, question for you. what are some other non-operative options that we can offer our scoliosis patients?
Thanks for asking that question, Dr. Crawford. So there are many different type of treatment options that are out there. You know, our role as physicians is to sort of distill and sift through all the treatment options that are out there and present to our patients the ones that are proven to work through a peer-reviewed journal process, research, etc. So if you Google scoliosis treatment, you'll come through a multitude of different things that can be done, but not all of them are useful or shown any efficacy in terms of helping control curve progression. So some stuff that's become very popular, chiropractic care, yoga, general stretching and conditioning, definitely has an effect on discomfort and can help with pain sometimes associated with scoliosis. However, there is no data to support that doing these alone is enough to change the progression or the natural history of a curve. So once again, you know, time will tell as research produces more information regarding some of these modalities, but right now they may be helpful in terms of building core strength and helping mitigate some of the pain associated with scoliosis, but has not been shown to reproducibly decrease the magnitude or the progression of the curve. Another alternative treatment method that's become very popular, that's been imported to the United States from Europe, is called Schroth therapy. Schroth therapy has a history going back into the 1800s, and by itself, not as effective, but when done coupled with the standard treatment such as bracing, has been shown in many studies to be effective in terms of reducing the risk of curve progression. What is Schroth therapy? Well, Schroth is a non-operative and with brace utilization modality that includes treatments with a therapist that's Schroth certified. So that's very important. You have to have a therapist that's Schroth certified because they have to be trained in the specific nuances of the technique. But the goal is to reestablish muscular symmetry by teaching the patient to engage muscles associated with the spine, to have a focused attention to those muscles associated with the spine, and also to help include a breathing component to help breathe into the curve of the spine. And these, once again, coupled with our standard treatments, have been shown to help with reducing curve progression. In our system, as part of our treatment team, we have two excellent Schroth therapists that are certified formally in Schroth therapy. One is actually actively practicing in the Woodlands, and one is also practicing in the Bel Air location. But remember, the most important thing is follow-ups as indicated by your physician, and getting frequent exams and if necessary, x-rays to make sure that the curve is not progressing. Question I have for you, Dr. Borden. When do you need to consider surgery for scoliosis?
Yeah, that's a great question. I think that is one of the biggest questions that parents have when they bring their children in for evaluation for scoliosis. But unfortunately, despite brace wear and school screenings and pediatrician screenings, sometimes either through presentation later or through progression despite that bracing, we see children with pretty large curves. And these curves, if they measure, you know, over 45 or 50, depending on the location of the curve, that's when the conversation about surgery begins. And the goals of surgery are always important to keep in mind. The goals are to prevent continued progression, prevent future pain, and then to correct the spinal curve as much as possible and as safely as possible in order to prevent future problems of continued curves getting bigger and other back pain and the things that Dr. Crawford talked about when she mentioned why we treat scoliosis to begin with. So those bigger curves over 50 degrees, those are the ones that we really talk about scoliosis surgery. And in our program, one of the things that makes us so unique is before any of the children that we see goes into surgery, we sit around as a group and all of our different scoliosis surgeons with their different expertise and background, we all discuss the indications for that surgery and the planned levels and how we're going to approach that patient and customize it to that specific patient. So I think that is one of the things that makes us unique in our program. As far as what goes into the surgery itself, basically to break it down, we place metal rods, screws, and hooks in. to help secure the rod to the spine and to derotate and straighten out the curvature. And once that's in place, we lock those screws and rods in place to allow for the bone to fuse together into a solid block. And that is what's involved in an instrumented posterior spinal fusion. So through an incision in the back, using rods and screws to straighten the spine. And once again, we allow the bone to grow together. And that bone, once it grows together, is really solid. And that's what's going to give you the longevity to live your life and to do all the things that you want to do, even though you've had surgery on your spine. And I think a lot of people either know someone or have friends or family who have had spine surgery, or maybe spine surgery long ago for scoliosis. And a lot of things have changed in how we approach and care for these patients in the operating room. And I'd be interested to know from your perspective, Dr. Crawford, what has changed from the past and how we approach scoliosis in the operating room surgically?
Right, that's a great question. And I know that a lot of people may know somebody who is treated for scoliosis with what's called Harrington rods, which, and they may know somebody who doesn't love their Harrington rods. But we've come to a greater appreciation of the true deformity of scoliosis is really a 3D deformity. And so it's not just that S shape, but it's also on the side view, a flattening of the spine, as well as a rotation of the spine. And so it's a very three-dimensional thing. And before, we were really only fixing one dimension. And so now with our new implants that we have, such as this, where we use what's called pedicle screws, potentially hooks, and they're joined together with these very powerful rods that are contoured in multiple planes in order to get correction, not just in one plane, but in all planes. As well as we use maneuvers to do what's called derotation of the spine. And that is a very visual thing that you will see where a large rib hump will be resolved and bring symmetry back. And with these new implants, we are seeing much better results long term. So the patients that are now in adulthood with these implants are not having those issues that the Harrington rods had in the past. And they aren't having to go back to surgery or having any issues with back pain on the long term, like we were seeing before with our previous implants. So we have a much different approach. The other thing too is we found that there's a lot of importance and value in being able to save levels of the spine from being fused. And so when we meet all the surgeons to discuss all of the patients, we really spend time focusing on what levels need to be fused in the spine and which ones can we allow to be free from the fusion and will correct on their own. And that really also helps with long-term results, having part of the spine that still has motion in it as well. Our surgeries too are very safe. We take a team approach to the surgery from beforehand, where basically the family gets to meet with not just the surgeon, but our anesthesia ahead of time too. And then the day of surgery, we have scoliosis team in the operating room, including our anesthesia team, our neuromonitoring team, who follows the patient throughout the procedure to make sure that there's no injury indicated through the spinal cord or nerves throughout the procedure. And then, of course, our scrub tech and circulator are very familiar. They do all of our spine patients. And this team approach makes it much safer procedure for our patients. So my question for you now, Dr. Mundluru, why don't you tell them a little bit about the recovery after the scoliosis surgery day?
Thanks, Dr. Crawford, for that question. So just to echo what Dr. Crawford was mentioning, you know, many people have had family members in the past undergo some sort of spinal procedure, whether in the adolescent phase or even as an adult. And we have to say that spine surgery in terms of the recovery phase of treatment has improved significantly. Back in the olden days, when the Harrington rod type constructs were used, patients would sometimes have to be recumbent in bed for weeks at a time. You know, now a typical post-operative course after surgery is done, the patients are expected to walk with physical therapy day one after surgery, and they're able to. You know, once again, this is talking about standard adolescent idiopathic type scoliosis. Usually the patients will stay on an average duration in the hospital for 3 to 4 days. The majority of patients are being discharged within that time frame. And then the planned return to school can vary, but majority of our patients are back to school in full attendance 3 to 4 weeks from the initial date of surgery. In terms of return to sports and activities, it's a gradual return. We don't want patients doing, more aggressive activities such as football or going on roller coaster rides, etc., till about 6 to 9 months. But there's a buildup to that. So patients are able to get more and more activity on board as they lead up to the full clearance for full activities at that 6 to 9 month interval. So once again, the postoperative course is a lot more faster than most people think after surgery like what we do. So, question I have for you, Dr. Borden, is do you treat other types of scoliosis and pediatric spine problems?
Yeah, absolutely. I think that's important to know. Our team here at UT in the orthopedic department, we are a comprehensive pediatric spine program. So not only are we well versed in adolescent idiopathic scoliosis, which is what we've been talking about in this series, but we also treat early onset scoliosis in really young kids. We do casting and corrective braces for those kids, growing rod surgery for young children that have significant deformity. We take care of children with neuromuscular scoliosis, either from cerebral palsy or other conditions, as well as children who are born with congenital deformities in their spine that develop curves. We also take care of children and adolescents with back pain, conditions like spondylolysis, spondylolisthesis, disc problems. We really are here to help help you navigate and treat any children with back-related problems, including scoliosis, but not only limited to that. And I do really think we have a wonderful program here. And I'd like to to finish off our talk tonight, I'd like Dr. Crawford just to maybe give us some insights as to what she thinks makes our UT pediatric spine program so unique.
Yes, so we have really strived to build a great team for our pediatric spine program, and we have a great collaboration of spine surgeons, pediatric surgeons that are coming together to give the best care to our patients. Through our collaboration, we're able to provide really high quality care for our spine patients. One thing that's always been important to us is each patient and each family is different. And what may work for one person may not work for another. And we have, as you can see, many options and approaches to treatment of scoliosis that we can offer you. And so we're here to listen to you, listen to the patient and the family, and come up with a treatment plan that's something that's going to be great for you guys. And if the scoliosis is one that does need to go forward with a surgery or a spine procedure, I think you get the sense that we also have a great team at the hospital that'll be there from before surgery to the recovery phase for helping you get the best experience possible out of that. And we really appreciate you guys tuning in and listening to us tonight. And if you have any questions for us, you can put questions into the chat box in Facebook here, and we are happy to answer those for you. Or you can reach out to us. We have information provided on the slide here. And please, anything at all, contact us, come in and see us. We will be happy to take care of you.
Thank you very much for joining us tonight for our second series of our Straight Talk Scoliosis Facebook Live broadcast. I hope you have a pleasant evening.
The best part of what we get to do is work with a very comprehensive team that has a singular passion, which is to provide the best care possible. It's been a privilege to be here and work with such amazing surgeons. And if there's any way that we can help your child, please reach out to us. We'd like to really do the best we can for you. Thank you.